Hi, this is Ria from Youth Navigate, and today we're thrilled to welcome Dr. Maggie Davis, a licensed clinical psychologist and associate professor in the Yale Department of Psychiatry. She's here to share her fascinating research titled An In Vivo Examination of the Relationship between Metabotropic Glutamate Receptor 5 and Suicide Attempts in People with Borderline Personality Disorder. Let's dive straight into some questions. So, our first
Great.
question is, when you designed this study, what was the most important question you were hoping to answer, and what was the answer you found?
Great question. What I was most interested in with this study was understanding if there were clinically meaningful differences in the brains of people with borderline personality disorder and people who had no history of psychiatric illness with respect to the metabotropic glutamate receptor, or mGlu5. And I think that word, clinically meaningful, is extremely important here because sometimes we see differences, but how do we know if those differences are actually going to be significant, right? Like people's heights are different. A lot of things are different about us, but how do we know if those are going to be predictive of the types of things that we're interested about, especially in a clinical setting? So we look at things like effect size, for example. Is this a big enough effect that it's probably something that's going to make a difference, that's going to matter in a clinical setting? And then we look at things like correlations between what we see in the brain and clinical constructs, like, for example, impulsivity, symptom expression, constructs that we know are related to suicide risk. And if there's a relationship between what we see in the brain or levels of our availability of mGlu5 and those type of things, we start to think, hey, maybe this is something that matters. And if it's something that we could move with treatment, we could really make a difference in this population.
Got it. So, now moving on to our second question. The paper notes that mGlu5 wasn't linked to impulsivity or general symptom severity. How do you interpret that in terms of suicide risk in BPD?
Yeah, really important question. So we did hypothesize that there would be a link between mGlu5 availability and both impulsivity and symptom severity in this population. I think there's a couple of reasons why we might not have seen that relationship. One is we had a relatively small sample size. If we'd had more people, I think we might have seen a significant relationship because we got close with a couple of those. Um, but variability in those measures and how some people answer them sometimes prevents you from seeing that type of a relationship. The second thing, though, is we're asking self-report measures. We're basing this on self-report measures. And notoriously, people with BPD have a lot of variability in what they're reporting and how they're reporting based on what they're feeling and based on the situation that they're in. So if you're asking somebody with BPD, how is your mood? How are you feeling? Are you feeling connected to other people? And they're at home by themselves, they're having a really down day, they're probably going to endorse more severe symptoms.
Hmm.
If you're asking somebody with BPD about their symptom severity and they're in a medical setting, you've been spending all day with them and you've established rapport, they're
Hmm.
less likely to report really severe symptoms. So another thing that we saw in our study pretty consistently was that people at baseline, the first time we saw them, which was over Zoom, reported much higher symptom severity than they did on scan day when they spent all day with us, when they were generally in a better mood because we've been spending a lot of time with them. And
Hmm.
that's something we see consistently when people have really severe symptom experience because of any psychiatric illness. What we refer to as insight can sometimes be affected, which can mean that the extent to which you are answering self-report questions consistently is also sometimes affected. Also, thinking about impulsivity when you're feeling pretty relaxed in a medical setting, I'm not sure you would respond to those questions quite the same way. So I think it's possible that under different circumstances, or if I was asking this as a clinical interview and saying, okay, think about a time when you were doing something impulsive, and I gave them a bunch of examples and asked them to reflect on that, there would have been a different outcome. It's also, though, possible that there are just no relationships between these constructs and mGlu5.
Hmm.
So we do see a relationship between mGlu5 and some constructs, though, that are related to suicide. For example, constructs related to the interpersonal model of suicide, like feeling that you're a burden on other people. I
Hmm.
think it's possible that mGlu5 may be a risk factor, a bio risk factor for a certain type of suicide behavior. Specifically, maybe not impulsive suicide behavior, maybe more planful or depressive tied suicide behavior.
Got it. Then why do you think mGlu5 activity was so much higher specifically in people with BPD who had attempted suicide?
Great question. I think there's a couple things that are important here. So the way we measure mGlu5 in the living human brain, we're able to measure availability of the receptor. So we
Mhm.
can't measure the total number of receptors or unfortunately even the activity per se. What we can measure is the number of receptors that are available for the radio tracer that we inject to bind to. So there's some really interesting findings that we've been able to come up with because of a combination of animal research and human research and postmortem research, looking across modes of research. I think that's really useful. For example, we know that with mGlu5, it may not be the total number of receptors
Mhm.
that somebody has in their brain that's different in psychiatric disorders. It
Mhm.
might be the number of receptors that are actually at the cell's surface. In people with PTSD, for example, they may have the same number of receptors, but there might be a difference in the trafficking protein that actually brings the receptor to the cell surface
Mhm.
or moves it away from the cell surface. So because that trafficking protein is working differently in PTSD, it looks like there's higher mGlu5 availability, even though there's the same total number of receptors. So you'll
Right.
have differences in postmortem versus in vivo in the living human brain findings. So I think in people with BPD, it's hard to say exactly why this might be. What I think we can say is it is a meaningful difference. It's a large difference, and it's a difference that's tied to and meaningfully correlated with, significantly correlated with meaningful clinical outcomes. So if we were to move mGlu5 availability, we could potentially move these clinical outcomes that are otherwise really hard to touch, which is really promising. And I think future research should dive into the biology and try to find out what exactly is going on here. Why exactly in terms of glutamate? Is it that there might be suicide risk in people with borderline personality?
Got it. So, talking about future research, could targeting mGlu5 lead to new treatments? And if so, what might those look like?
Absolutely, yes. This is something that's actively being pursued by a couple of different
Mhm.
companies right now in post-traumatic stress disorder. It's not something, as far as I know, that's being looked at in borderline personality disorder, and I would
Mhm.
love to see work moving in that direction.
Mhm.
Specifically, there's two types of drug classes that, based on these results, could be promising. Antagonists, which would reduce the activity at mGlu5, or negative allosteric modulators, which would sort of modulate the activity of mGlu5, not necessarily block it, but reduce it, right? And
Mhm.
so I think both of those, based on what we know from, again, a combination across fields of literature,
Mhm.
could potentially have promise here. For example, in animal literature, we see that negative allosteric modulators in antagonists tend to have an effect on being able to induce fear conditioning, which is what
Mhm.
leads to PTSD. And
Right.
what can contribute, trauma experience and the negative aftermath of that can contribute to borderline personality disorder.
Mhm.
So if we modulate mGlu5 in that way, there's a possibility that we could contribute to symptom cessation, some symptoms getting better, and potentially the disorder getting better, treatment being more effective in terms of therapy too.
Got it. And what is one thing you hope youth readers will remember about this study?
I think what I would hope that they would remember about this study is
Mhm.
that there are differences that we can detect in the brain of people with borderline personality disorder.
Mhm.
And that's something that there's not a whole lot of literature other than this study and a few others that actually have demonstrated. Um, a lot of literature just doesn't look at BPD in terms of neurobiology. It's an underfunded field. There's a lot of stigma around BPD because of risk. It's the only psychiatric disorder for which suicide and self-injury are actually in the diagnostic criteria. And I
Mhm.
think that that contributes to people being less willing to work with people with BPD, people
Right.
being less willing to do research with people with BPD.
Mhm.
Um, and that's dangerous because right now we have no medications, not one, that's FDA approved for the treatment of
Oh,
borderline
wow.
personality disorder. And we lose so many people with BPD to suicide, to premature mortality for a lot of different reasons. So when we do this research, we see differences in the brain of people with BPD. And that means if we keep doing this research, we will find solutions. And to me, that says there's hope and we should be doing this work.
Got it. I hope the youth readers remember that. And our last question today is, as someone deeply involved in both research and therapy, how do your patients inspire or shape your scientific questions?
I love this question so much. The answer is profoundly. I am a clinical psychologist first and at
Mhm.
heart. That is my training. I did not start doing neuroimaging research until I was a postdoctoral fellow.
Mhm.
And I started doing neuroimaging research in the first place because I'm a trauma-focused psychologist. I started out in PTSD research and BPD as well, and became frustrated by the fact that therapy works. I believe in it. I have seen it work and be effective. And the reality is that therapy takes time. Therapy skills take time.
Mhm.
And that means that for people that we lose to suicide, especially impulsive suicide, which is arguably more likely, at least in some cases, in trauma-related psychopathology like PTSD, like BPD, we don't always have that time, right? So if we could develop something in terms of effective treatment for suicide to reduce risk, we could give ourselves the time to let therapy work, to make sure people have the resources to even access therapy. And as a therapist, that's incredibly important to me. I think therapists and people who are grounded in the communities they're trying to serve ask better research questions fundamentally because they understand the people that the research is being done, it is targeting, right? Because of talking to and working with people with BPD and being a family member of people
Mhm.
with BPD and having loved and loving people with BPD, I feel that I have the privilege to understand and ask questions about what is this like? What is this experience? How would you ask this question? How might you react to this questionnaire? And because of that, I think I can do better research. I think that's something that increasingly our field is taking to heart. And
Mhm.
I think especially in neurobiological research, it's making us better. It's allowing us to close some of the gap that we're seeing in terms of lack of reproducibility in science, finding different outcomes. I think part of the problem there is there's a lack of clinical psychology in neurobiological research. And I think a part of that is there's not a whole lot of crossover in training. A part of it is there's a sort of bias that I think some clinical psychologists don't really appreciate in
Mhm.
terms of thinking about neurobiology and biological research as real in a
Mhm.
way that psychological research isn't, which I feel a way about as a clinical psychologist. Um, yeah. And I think for that reason, about half of the work that my lab does and that I do personally is advocacy based. We work with groups like the National Education Alliance for Borderline Personality Disorder and Emotions Matter. For example, on October 30th this month, we are having an outreach event. We are having somebody with lived experience. She's a former Miss Connecticut, actually come to speak about her experience of borderline personality disorder and substance use. And we're having the Fishman Family Foundation come to Yale's campus and give out Narcan, which is a substance that's capable of preventing opioid overdose, and actually train anybody who comes from the community or anybody who comes from Yale's campus or anybody who's interested on that and give them doses of Narcan so that they can have that safety and learn about what BPD is, what BPD and substance use is, and why it
Mhm.
is that that relates. Doing things like that, I think, makes us all better and makes us better researchers. Very long answer, but I hope it's helpful.
Thank you for your lovely response. So I think in listening to both science and lived experience, you remind us that every discovery begins with compassion and every neuron tells a human story. And I think your findings like echo what youth advocates everywhere believe, that the smallest insight to the mind can open the largest door toward healing. So thank you so much for today's interview. And yeah, thank you so much for your research too.
My pleasure. Thank you so much for your time.